Welcome to Voice for Infection Prevention, where we explore the latest developments, challenges, and insights in the field of infection prevention and control. With a passion for promoting patient safety and healthcare excellence, we're excited to bring you engaging discussions with experts, leaders, and innovators in the field. So whether you're a seasoned professional or just beginning your journey in infection prevention, welcome to the conversation. This is Voice for Infection Prevention.
Welcome back to Voice for Infection Prevention. Today we have an incredible conversation with Maimuna Jatta, whose journey into infection prevention is truly inspiring. From starting her career as a nurse in the Gambia to becoming a system director of infection prevention in the United States. Maimuna's path is a testament to resilience, leadership, and continuous learning. Maimuna's transition into infection prevention wasn't immediate. She gained experience in home health, skilled nursing, and community hospitals before actively volunteering with an infection prevention team to learn the ropes and break into the field. Her passion for patient safety and public health drove her to earn her CIC certification within 1 year, rapidly advancing into a senior leadership role during the COVID-19 pandemic. In this conversation, we discuss how she navigated the challenges of credentialing in a new country, built a structured infection prevention program across multiple hospitals, and advocated for dedicated infection prevention resources and healthcare systems. She also shares valuable advice for aspiring infection preventionists, emphasizing the importance of mentorship, adaptability, and proactive learning. If you're looking for insights on career growth, leadership in infection prevention, and the evolving role of infection preventionists in healthcare, this is an interview you'll want to listen to. Let's get into it.
This episode is sponsored by Clutch Recruitment, the leading recruiting firm in the country, recruiting exclusively within infection prevention and control.
All right. So my first question for you and I'm looking at your resume here. You took a pretty interesting path to get into infection prevention. So I just want to hear kind of where you went to school, like what your educational background was, and then what you first did within healthcare, but then ultimately led to you discovering infection prevention.
Yeah, just like you said, I took a few turns before ending up in infection prevention. I started my career back home in my home country, the Gambia, as a nurse. I did 3-year ADN. Our ADN program was 3 years, so I did college for 3 years, graduated with a registered nurse degree. I worked for like a few months and then got school in the US. So I came in for my bachelor's degree, which landed me in Des Moines, Iowa. When I came, because our program in the Gambia was not fully accredited and not recognized in the US, I had to got enrolled into a 4-year program. So all of that credit somehow did not transfer. So I was starting all over because the educational system was also a bit different with the US. So I kind of understood why that did not transfer over. I did 1 semester, realized that some of the courses that I was taking were just repetition of what I had studied. And so I started studying for my NCLEX the second semester. And by the first year, I got my NCLEX. I passed my NCLEX, so I got registered nurse in the US that allowed the school to accept some of my credits from my previous college in the Gambia and transfer that over. So I was able to get my bachelor's in 1.5 years instead of the 4 years, which was great.
Great. Okay.
After my bachelor's, I started working in a community hospital in Des Moines, Iowa. I enjoyed nursing. I've always loved caring for people, taking care of people. I like that I can share my humanity with people. I like seeing people come in very sick, but within a couple days, we get them out of the hospital. So that felt good. And I think that was what kept me nursing longer than I probably needed to be, because while I loved it, it was not what I had always wanted to do. When I graduated high school, I was torn between going to medical school and studying computer science. But the medical program at the time was like a 7 year program. And then you had 3 years. So I was like, I don't have 10 years in school. Like, that's a lot. That was my thought at the time. And then we did not have a computer science program at my university back then. And so my brother had a friend who was a nurse, a great nurse. He enjoyed what he did, and we were very close. And somehow he talked me into, he's like, check out the nursing program. It's great. You'll love it. And so he got me the application form, and I filled it out. At the back of my mind, I was also thinking public health was another
Uh-huh.
area that I was really interested in, because I grew up volunteering for the Red Cross. And so that kind of put me in the public health arena somehow, because we'll go out helping in disaster areas. Like in my country, it was around floods, or sometimes just, a house caught on fire and you're out there trying to help
Hmm.
however you can. So it was things like that that kind of introduced me to public health somehow. But I did not know at the time that that's probably what I needed to do. So I went into nursing, and then while I was in Iowa, at my university, I had a really great roommate who turned out to be a great friend. She will always say, Maimuna, you're a germaphobe. You should be an infection preventionist. I was like, what's that? Because I never heard of that. We don't have anything like that. We have public health officials, but infection prevention was not something that I have heard of in my country before coming here. So she would throw things like that. And I was like, what is an infection prevention? She's like, oh, you should look it up. I think you'll be great at it, because you really don't like germs, and you're pretty smart, and you like to teach. So you should look into it. And so I was like, okay. And then I looked into it. I was like, this is very interesting, because it's kind of like a good marriage between my nursing background and the public health aspirations that I had, that I never pursued. And so when I was ready for my master's degree, I looked into getting a program that will help me get some knowledge and skills to better understand the role. Because even she was throwing the word out there, because she worked at a hospital that had an infection prevention program. And so she got to interact with the infection preventionists, but she didn't understand what it was. She just knew that they were very big on hand hygiene and other things. And so I started looking into, I was like, this is pretty cool, interesting. Um, it was hard to find a program in the US that kind of would help me with the skill sets and the knowledge that I needed. But I was fortunate to find the one program at the time was with American Sentinel University, now on the post university. And they had an MSN program with a focus on infection prevention and control. So I took it, really enjoyed the classes, enjoyed the material that we were covering, and it just kind of felt like this is kind of my niche. This is what I really enjoyed doing. And so before I finished the program, I had moved from Iowa to Roanoke, Virginia for my current hospital where I worked at. And they had a great infection prevention program. I kind of found my way in to get to know the people. I started volunteering with them. They had Infection Prevention Day each year during that Infection Prevention Week, and they would do a big educational activity, a whole day of just education. So I'll volunteer and just be like, hey, let me come and help, because I wanted to see if this was really something that I wanted to do. And so during the course of my second year of doing that, really, they had an opening for infection prevention, and I applied and got in, and the rest is history. I've been enjoying this work ever since. But prior to really getting into that, I've done home health, I've done like skilled nursing facility, just trying to find my niche in healthcare. And it wasn't until I found infection prevention that I've really been able to really every day enjoy what I do, because this is what I've been looking for the whole time.
Yeah. No, that's fascinating. So tell me, when you started doing some of the volunteer work and kind of helping out, you said that went on for, did you say a couple of years you were doing that?
Yeah, it was just about a year and some months. So I did it the 1 year, and then the second year I did it again during Infection Prevention Week. At the same time, I was also kind of like the unit champion for our unit. I was a champion for infection prevention. So that allowed me to work very closely with our IP at the time. And so that's how I got introduced to a lot of the concepts that I now kind of have grown my knowledge in.
Okay. And then how, I was trying to think. So if someone were to be interested in it like you are and want to get involved, were they like readily wanting help, or like were they trying to get people to do what you were doing, or did you kind of force your way in and make yourself known, or what was that kind of interaction like in order to start helping?
So the IP that I had for my unit just happened to be a great IP. She was a nurse by background and just grew in love with infection prevention. So she was very willing, and she was actually very excited to see a nurse that was interested in kind of talking to her and bugging her with questions when she will come to round, because usually the nurses are running away. And so she was very intrigued, and she would answer my questions. And so we were talking, and she's like, we have infection prevention day coming up, and we have a lot of activities, and we are looking for folks to help man some of the tables, because there's going to be lots of educational activities, and we need more people than we have in the department. And I was like, oh, sign me up. It just happened that at the time she was heavily pregnant. So she was also like, it's around my due date, and I might not even be here for my educational table that I am responsible for. So if you would like, we can make sure that you have everything that you need to know just in case. And it just so happens that she was on maternity leave when the day came.
There you go.
So
Okay.
that was how I got into it. But then there were other nurses from other areas who also volunteered to help.
Gotcha. Okay. And then, so that was, looks like that was August 2017 when you officially stepped into the role, which is great. And it looks like you got your certification in infection control the next year in 2018. So tell me, it's a couple questions here. One, was that challenging for you, or did you pick up on it pretty quick and your nursing background kind of really help in that? Or did you put a lot of time into studying for that test and making sure you could do it? Because that's 1 year is a quick turnaround to take it successfully.
Yeah. No, that's really true, because when I took it, the department, a lot of the IPs were like, "Whoa, like we haven't even." But I think my master's degree, because it was solely focused on infection prevention, I could have taken that test right after graduating, because it prepared me. It looked at all of the core competencies. The CB core competencies were all covered in the program. So I came in. Theoretically, I had all of the knowledge by the time I started in as an IP. I just needed the application of that knowledge in practical, in real life scenarios. And so the first year I really spent trying to apply that and, building those relationships, while also looking at the surveillance piece like the NHSN. That was foreign to me, so I had to learn that. But no, it wasn't hard to take the course. I think at the time you had to be a year before you could qualify to take the exam. And so that's what I had to wait for.
Gotcha. Okay. So when did obviously you had the knowledge. I mean, you were able to complete the test, and you learned a lot in the master's program, but when did you feel like you really had a handle on what you were doing?
That's a loaded question because even though I came, which I think I had an advantage over a lot of IPs, even those that I had met in the department, because one, I had that clinical knowledge as as a registered nurse and have worked in different healthcare settings, so that kind of helped me a lot. Um, I also I was a science student, and in college, I took two biology classes while I was in my undergrad. So that microbiology was not as difficult as it would have been for a regular nurse because microbiology coverage in nursing was very basic. And so for a nurse, when you come in, that's the area that you really need to focus a lot on learning as an IP. I had some advantage because I took those biology classes, and so it helped me a lot. And then my program prepared me epidemiology. I had the basic concepts. I had those very well covered, and I was very comfortable in those. Um, but there were aspects of the role that I don't think any education could prepare you for. I needed to learn those on the job as well as navigating the relationships. So that was the one thing that I spent my first year really doing was trying to navigate cultivating those relationships because the role of the IP, while we have all this knowledge, we are not the ones that are kind of translating that evidence to practice. And so you need to have these really strong and trusting relationships where you can, influence that change on the front line. And so that's where I put a lot of focus on. And I think what helped me be able to have that mindset was being a nurse on the front line. There were some things that I did not appreciate when my APs would come and be like, hey, this is what you're not doing right. And so I brought that experience and understanding and being able to speak from a place of knowledge and experience when I talk to my colleague, the nurses on the front line, about why they needed to prioritize, like changing a catheter or a dressing or even putting a date on on the dressing. As a nurse, when you've run around for 12 hours just trying to keep a patient alive and that you haven't even taken a break, and then somebody from outside just comes in to tell you you forgot to put a date on the dressing, that becomes so minuscule and it almost sounds petty and it can be frustrating. And so I take that knowledge with me and use that to my advantage to help me cultivate these relationships while also trying to educate. I think that really helped me. A lot of my successes, I kind of trace back to having that experience myself. And so I use that to kind of help. But it was a learning curve despite all of the knowledge that I came in with, because infection prevention is one of those um, healthcare fields where it touches everything. One day I'm like a structural engineer trying to figure out issues related to a flood that got into a building, and now we're trying to figure out how do we make sure that this building is safe for occupancy. Or on any given day, there could be you're dealing with an outbreak here, which is kind of normal infection prevention stuff. But then there could be other things that just I wasn't prepared for, like construction. Infection prevention in construction was not something that I covered in school, but I quickly learned that, yeah, as an IP, that's also your responsibility. Um, and so a lot of those things like disinfection, sterilization, we covered it in school, but until you really get into the nitty gritty, you don't know what you don't know. So I spent a lot of my first year really learning and applying these skills, as well as continuing to explore how far infection prevention stretches. But I come to find out it's like it stretches all across everything in healthcare, from the buildings to the people. You work across all departments and all disciplines, and so that was, I think, a learning curve. despite all of the knowledge that I came in with.
So how big is the hospital were you at this? I know you're still in the same system, but at the time, how many IPs did you have, I guess, working alongside of you, and who did you report to?
Oh boy, that was pre-pandemic. We had 6 IPs for the facility. It's a 700 plus bed hospital. But we also had a very big outpatient program, and the 7 IPs covered both inpatient and outpatient programs. So we had a director that we all report to, and we all have assignments both inpatient and outpatient, and surveillance too.
Gotcha. And then, so I'm assuming, kind of based on what you've said, but it sounds like you had a fairly strong support system when you walked into the role and had people you could rely on. Is that fair to say?
Oh yeah, the program was already established. They had a really strong foundation. Was it as resourced as it was supposed to be? No, we would come to find out during the pandemic. But they had a strong established program. At that time, we had our director was an IP who kind of grew into the role. We had seasoned IPs that were like decades into the role as infection preventionist, that I just kept like bugging and trying to learn as best as I can from the experience. And it was a very diverse program. I think that was also very helpful, in the sense that we had IPs with different backgrounds. We have microbiologists, we had MPHs, we had nurses. So we kind of were able to feed off of each other's strengths. But yeah, we had a great support system, if to speak at that time. It was just now when I look back, considering how much we have grown the program, I was like, man, that was really, how did we do that?
Yeah. Okay. And we'll get into that here in just a second. So now, one more question before we go into kind of your promotion there a few years later. But when you went to get your certification, was that something that was required? Was that something that, I mean, did it give you any sort of financial advantage to do that? Was that just something personally that you just wanted to have? Or what was your primary motivation for that, to go and do that?
When I took my certification, it was not required. It will become required later. And really, there was no like promotion that came with it. You'll be reimbursed for passing, and getting certified like any other certification. But I'm a lifelong learner. I thrive on accomplishments. So I set my goals to something. I set myself a goal. I need to accomplish that goal before I could rest. And certification was something that I had certifications in nursing. And so when I knew there was a certificate, I think I just needed to also validate that the things that I thought I knew. And so taking that certification was something to be like, okay, I think you got it. And so it was a personal goal. And
Excellent. Okay, that's good. And then, okay, so you were then an infection preventionist for 3 years. It looks like at some point, maybe right as COVID was hitting, you got the senior thrown in front of your infection preventionist title. What was that about? Was that just a way for them to pay you a little more? Did they want to hire people underneath you, or what was that transition? How did that come about?
so that was at a very interesting time. Obviously, during COVID, infection prevention started getting a spotlight, as deservedly, because we were working around the clock, trying to keep hospitals open and operational, and also ensuring everyone's safety, both staff and healthcare workers. And so it was a very interesting time. Unfortunately, our director retired around those times, so there was a huge vacuum for leadership at a time when we really needed infection prevention leadership. I had no leadership background at the time, and I had been a team lead in my clinical role, but I haven't really managed people. And at, at the time, I don't know if the organization was ready to take that chance because it was big, a big responsibility. And I don't know that if I was even ready then. Even
Hmm.
though I was doing a lot of the things that a director would do, but I was also very hesitant about taking on the additional responsibility of leading teams. And so the organization, as we started looking at the deficits in the department when it comes to both human resources as well as other resources, we realized that the staffing matrix did not meet the needs of the organization at that time. And so we started this expansion program. And part of that was creating some type of a role that would help support and develop the training program for these new IPs that we need. But at the time, during 2020, 2021, there were no experienced IPs that were willing to relocate or change their jobs. It was just infection prevention in general saw what would be maybe an attrition, or because a lot of the experienced IPs that have been doing it for years, just like my director at the time, were retirement age. And so the pandemic just forced them to retire or just
Hmm.
brought that to the forefront. People started looking at what their priorities are. And for a lot of people at the time, it was spending more time with the family. So we did not have a lot of experienced IPs wanting to take those roles. And so we had to hire fresh MPH graduates and train them. And that required a lot of work, planning, and developing a training program from the ground up was a lot of undertaking. And so part of my promotion was to lead those efforts. And so I became a senior infection preventionist, took on that role. In addition to training and onboarding the new IPs that we were hiring as we grew the program, we also had a COVID exposure team that was fully focused on contact tracing and making sure that healthcare workers cleared and brought back to work as quickly as possible, making sure that our patients are kept safe. We had a big contact tracing program. And so I was kind of leading that program at that time. And we had to build that program from the ground up, including all of that infrastructure that went with it. And so it was a leadership role, but I did not have anyone reporting me through me. I was managing programs. So I managed the inpatient program and the COVID exposure program.
Gotcha. Okay, I want to dig into this reporting structure a little bit. So you said initially there was a director and then 6 or 7 staff level IPs at the time. Director leaves, so then there was no manager at the time, right? There was no other leadership position. Okay, so then when they gave you a senior title and gave you some additional responsibilities, were you the only IP that was designated as a senior IP at the time, or were there multiple people that got the senior IP title?
So we were two in the department. I had inpatient program in the COVID exposure, and then my colleague had the outpatient program in our community hospitals. So kind of supporting those programs um,
Gotcha.
for both onboarding as well as program outcomes and things like that. And
Gotcha.
we had an interim director to help with the administrative stuff at the time. They were not an IP, but had great leadership experience and very good with navigating um, challenges when it comes to staffing as well as growing teams. And so, because we were growing a team and we needed that strong administrative lead, they were brought in to help support those efforts.
Gotcha. And then you mentioned kind of leading or heading up this kind of MPH deal, onboarding them and training them. Are you guys affiliated with the university, or how did you find MPHs that were interested in this?
Interestingly, I think because a lot of MPH grads were kind of at a time when infection prevention was a spotlight, they were also learning that, oh, I could get a career field outside of the traditional, public health arena. And so we were getting a lot of applicants that are MPH graduates, soon to be graduates. We're affiliated with Virginia Tech, and we will grow relationship to where we now provide internship for their students. But at the time, we just had that affiliation because our organization is affiliated with Tech. And so we kind of got some applicants from Tech, the MPH program, but we also had applicants from all over the country, new grads that are just looking to go in and serve because they know there was a need.
Gotcha. And then you mentioned MPH specifically. Did you guys have any sort of program for RNs that come out? I mean, I know it's not necessarily common for a registered nurse to go straight from school into infection prevention. It seems like they tend to work the floor for a little bit before they get introduced. But do you guys have anything like that, or do you have any interest from registered nurses just out of school?
Yeah, we had not necessarily a lot, but we had an individual that was a registered nurse, recently graduated and just applied, and we took a chance that did not work out very well. We'll come to learn that clinical experience is really helpful for nurses, just because the nursing program, I think, is not as heavily focused on some of the epidemiology that the MPH programs come with. And so the clinical piece is what helps registered nurses really strive and really thrive in infection prevention. And we learned that. And since then, have not really pursued that. Well, we're willing to mentor and kind of help guide them, but we always advise to get some clinical work experience because it will come in
Gotcha.
handy.
Gotcha. And I'm going to put you on the spot here a little bit because this is kind of a hot topic. But so for somebody just out of school, no experience really working, I mean, maybe an internship or something, but who has the bigger learning curve to do well in the role between a RN, MPH, and microbiologist?
Ooh, that's a really good question. And I think each of those backgrounds come with strengths and limitations. Like, I like my microbiologists. They're very detail oriented. I call them my inner people. Like, they don't miss a detail, but the people skills, unless you are like a natural, because they're hidden in the lab, they don't really interact with a lot of people. And so that's an area of learning for them. Now, PhDs are great. They're great with data. They, especially my new grads, young into the infection prevention field, very creative. They can find like the most creative ways to drive the message home, but the clinical piece is missing. And so that's a big learning curve. And then you have the registered nurses. I think the biggest struggle for my RNs, me included, is, when you're an RN and you're walking on the floor or wherever you're walking, the clinical setting, I think what drives you is seeing people get better. And so that journey of observing the patient that you admitted 2 days ago is now like walking out and going home, walking out of the ICU and going home. That instant gratification, you kind of, if that is your primary driving force, infection prevention can feel a little bit like, oh my God, I don't see the impact. And that's something that I struggled with until you kind of get that this is bigger than just the one individual. You have a bigger impact in this role. And so a lot of nurses kind of struggle with that, kind of marrying what they're doing on a daily basis and seeing that outcome in ways that are different from what they used to see, from one patient to the other. And I think that is, and then if depending on your background in training in nursing, if you haven't really dealt with a lot of data, it becomes a learning curve for you, because nursing is typically not kind of data driven in the day to day work that we do. Everything is kind of built on the background for nurses to just take and do the work. We're not the ones that are kind of looking at the data and trying to use the data to work for us. And so that is a learning curve for nurses. I don't think I've answered your question, but I do think that each of the roles, they bring in something unique. And when you add all of that together, you get like a really good and strong program. And that's what I like.
Gotcha. No, that's a good answer. I put you on the spot there too, because so many different strong opinions on the topic. But no, I mean, what you're saying makes a lot of sense.
Yeah.
All right. So it looks like you held the senior infection preventionist title for about a year and a half before they promoted you into a director role. So I want to know how that came about. I mean, the timing, COVID had kind of settled down by that point, so it probably made sense to have a permanent solution that wasn't going to be too crazy at the time. So the timing of it makes sense. But did you get moved in there pretty quickly after the interim left? Was there a application process? Like, was it difficult to get that job, or was it just kind of a natural, no, this makes sense to everybody, and you just kind of slid right in because you're already doing some of the stuff? Or what did that promotion actually look like?
Yeah, so the interim did not leave, the interim promoted. So they opened up a senior director position for infection prevention at the system level. And so the interim kind of ascended to that role. And so that left the director position open. For to be filled, and I applied. I think other people applied, and so went through that interview process, and I got the job. I like to think it's because I've proven myself, to be effective, but also to be, a resource, and my capabilities maybe got me the job. I don't know. I'm not privy to who all applied, but I do know that there were other applicants.
Yeah, and you're certainly qualified for it, so it makes sense. Did you? Okay, so the interim director you said got promoted to a system director role. Was that specifically in infection prevention?
System senior director for infection prevention, yes.
Okay, wow. And their only infection prevention experience was pandemic time oversight.
Yeah.
Impressive.
Yeah.
Okay. I mean, I think there's a storyline there, and that leadership is a big deal. And I feel like, and we've had a couple people on that have hinted at that. I think you can. It's really easy to ignore the leadership skills when it comes to this profession and what's there. So clearly, that's significant. But okay, did they create that system level position for the interim and then left the director position?
Yes. Yes. They created that position.
Gotcha. So then how did your actual day-to-day role change when you got promoted from senior to director?
So when I became director, I became the system director. So I had oversight of all of our hospitals, the outpatient program, inpatient program, and our COVID exposure team was still active back then. Yeah, it was the system director role, managing the entire program at the system level.
Okay. And how big is that system?
We have 6 hospitals, including a level 1 trauma center, a level 3 NICU. We have 2 mental health hospitals, and an inpatient physical rehab hospital, and then over 250 ambulatory sites.
Oh, wow. Okay. So that's a pretty significant jump then in responsibility. And you mentioned early on, it was you're at the main hospital, 6 other IPs, and you said it didn't quite meet the needs of the hospital at the time, and you've since kind of changed that. What does your staff look like now? And I think I spoke over you. I think you may have mentioned the direct reports, but what's the makeup of your staff, and just how big is it, I guess, and what's your ratio for like staff to occupied beds?
Yeah, so we try to go with 100 or less per IP.
Mhm.
And for community hospitals, even though some of them are critical access, small hospitals, we do have one full-time IP. It used to be the IP was also the employee health nurse. We divided up those roles so that the IP is full-time focused on infection prevention. So we have IPs at each of our community hospitals. At least one full-time IP. Our second largest hospital is about 150 beds, has 2 IPs. And then for our main hospital, which is over 700 beds, we have 7 IPs, inpatient
Okay.
only. So whereas it used to be 7 IPs in addition to the outpatient program, now we have 7 IPs that are just dedicated to hospital services. And then we built an outpatient program and have 4 full-time IPs that are covering the outpatient program for the entire system. We also centralize surveillance so that hospital
Excellent.
IPs are not focusing on surveillance. So we have a centralized surveillance team that is made up of 2 IPs and 3 infection prevention assistants that kind of help with the data abstraction and stuff like that.
Excellent. Excellent. Okay. Now, was it COVID and the spotlight that came with it that allowed you guys to put the resources into the program that you needed?
Definitely. At the time that our previous director retired, we also lost a few of our seasoned IPs. They were just burnt out. The burnout at the
Hmm.
time was just real. And so we lost them. And that kind of did not help, but it also helped us to be able to advocate for resources. We had a very engaged medical director that was a big advocate for infection prevention. And so, with his support, we were able to build a case to the organization of why they need to build a strong program. And thankfully, I think we got the ears of the C suite and they invested, and I think the investment is paying off.
Awesome. Awesome. And then you mentioned how you handle critical access hospitals, or the critical access hospital that you have within the system. And I ask because on the recruiting front, we obviously do a lot of work with critical access hospitals, and it's very common to see employee health tagged on to the infection prevention role. Um, it's also 9 out of 10 people, when you start pitching a job, the first thing they say is, if it's over employee health, I'm not interested. So I want to know. I imagine you played a role in that decision from stripping it down and kind of getting rid of employee health under that role. But can you speak to that? Maybe why you did that, and what your recommendations would be for other critical access hospitals?
So, employee health is a very important job and very important role. So is infection prevention. When you add those two together, now this individual is trying to figure out which is more important. What do I prioritize versus not prioritize? And it's a big conflict internally for the individual, especially if they're passionate about what they're doing. It's just not a healthy balance. And making it a healthy balance is just unrealistic. And especially during COVID, when we were grappling with sick employees as well as figuring out when people can come to work, hospital administration is trying to figure out staffing because we need to keep hospitals operational because of the influx of COVID patients during the surges. And you also have lots of changes in guidelines and recommendations. Remember those days when the CDC was updating guidelines every day at 4 p.m. And it's so the IP has to be on the front line trying to help the frontline teams educate them on these new guidelines and what they need to do. And you can't do that while you're trying to serve those employees that are sick or that need employee health. And I think reality just hit quickly, and the organization realized we are setting these people up for failure. They can't do both of these important roles at the same time. And I think oftentimes what happens is when you put someone in that position, employee health, a lot of it, what they do is required by law, it's regulatory. And so that becomes priority, and infection prevention just kind of falls on the lower end of that long list. And so that's what we needed to speak to. Is like infection prevention is very important. It's not a role that you kind of keep on the side and pick up when you can. It has to be an active role every single day. And we can't do that if we are not able to really look at these roles and separate them so that we can have individuals that can focus on each of these very important roles and be able to do the work that we need to do for our healthcare workers. They deserve it. And I think that kind of was the message. But it just became quicker. People were just burnt out. People wanted to leave the roles because they were being asked to do too much and they can't. And if you're like me that cares about what you do, you go home feeling like you have not accomplished anything because you're just running around, not able to meet any of your targets for the day. And it's just been an addition to the burnout that was already happening during COVID.
Gotcha. No, it's a really, really strong answer. Um, Tell me this, and I'm changing gears a little bit, but um, it sounded like initially you guys had a team, 6, 7 IPs, and everybody reported to a director. Has that changed, or did you have 18 people that are directly reporting to you in the role, or did you guys add any sort of? I mean, I know you got the senior role for a second. Did that stay around, or well, guess what is the reporting structure starting with the people just out of school?
So we don't have any layer between me and the IPs. Unfortunately, that is something that we're continuing to advocate for and work towards. But everybody reports to me. We have me, and then you have my IPs.
Yeah,
And then for the COVID exposure team, unfortunately, we were able to advocate for team leads. So we had team leads for that team because that was a lot for me to have to manage the day to day. And so we had team leads kind of managing the day to day operations of that team up until we were able to kind of shrink that team now that COVID has normalized or it's endemic. We were able to shrink that team and integrate the few people that we left into the infection prevention program.
gotcha. Gotcha. Okay, I've got two more questions for you, and then we'll wrap up. Um, but you had a pretty significant jump from senior IP to being the director over all of these people. I want to hear about kind of the learning curve or challenges there, specifically to leadership. I mean, was that a big transition for you going to now managing multiple facilities and a lot of people? Like, was that difficult, or was there something else that was more difficult? Or I guess what was that transition like?
So I think, fortunately for me, the senior IP role, even though it did not come with direct reports, it allowed me to kind of slowly ease into leadership in a way that I don't think I would have had the opportunity to if I was just from IP to director. Um, I was managing a lot of the things that I'm currently doing as a director, except for the managing people piece. I was also, because I was very integral in the training and onboarding. We had a 1 year IP onboarding program for our new IPs coming into the field. So that allowed me to kind of cultivate and build those relationships with the IPs. And I think when I assumed the director role, it was just a natural progression of what had already been established. Obviously, leadership is I continue to learn and grow in my leadership skills. I think those interpersonal relationships were definitely something that I had to approach differently because I am kind of like I thrive under pressure, and that can be annoying to a lot of people. And so during crisis, I'm like, let's go. Like, and people don't always react to that. But also just learning how to navigate the different disciplines and being able to be an influential leader because you need buy-in from everyone if you're going to be successful in anything that you do as an IP. And so those relationship skills are something that I've had to learn and I continue to. But I think just easing slowly into the senior IP role and the leadership vacuum that was there for a while and just having to naturally by default take that responsibility has helped me so that when I took over the director role, it was just kind of a title change, but the responsibilities I was already undertaking.
Gotcha. And you're obviously involved in a lot of hiring. I mean, for many years now, whether it's just out of school or other positions, I'm sure. But can you speak for a second on what you look for in an IP? Like, I'm sure by this point you can kind of spot, like, okay, this is a good one. What are a couple of things that like just really jump out to you that gives you the confidence that they're going to be strong?
Oh, for me, it's like the first question I always ask is, what's your motivation? Infection prevention is such a unique field. It's not like anything in healthcare, and it can be lonely, especially if you're like the sole IP at a facility. You're the only one who thinks the way that you think, and that does not come easy. So it's like you either have to have a strong passion for this work or you're not going to survive. And so that is always my first question is like, what's your motivation? And I want to hear those stories. Like what brought you into infection prevention? What are you looking forward to? Where do you see yourself in 5, 10 years from now, understanding that the field, while it's very important, I like to say that infection prevention is the most important field in healthcare. I know nurses would want to nurses who want to slap me if I say that, but it's a very important field. We're the only discipline that touches everything in the healthcare system, and so for me, it's like you kind of you need to have the drive and the passion, but you also need to understand that up until the pandemic, a lot of IPs kind of like the role fell on their laps or they were just tired of the clinical and wanted like an 8 to 5 job and somewhere to retire. And that's how they ended up in infection prevention. That's no longer the yardstick. And so for me, I'm looking for like passionate IPs, but also people with drive because the infection prevention needs to go a long way. And so I'm looking to this new generation to take it where it needs to be. And that is that's the person I'm looking for. Like, what are you bringing in, but what are you hoping to get from this field, as well as where are you planning to take the infection prevention? My biggest, I think, success story as a leader is seeing IPs that came under me doing great things. And that's kind of what I'm looking for. I want people that are going to make me look good. When I see them on the national stage, I'm like, that was my IP. That's what I
Yeah.
want.
No, that's great. That's great. And obviously, a lot of people that will listen to this are people that are entertaining going into the field or have just gotten into it. So I really just want to leave it up to you in closing. But do you have anything to say or any motivation to those that are exploring exploring a infection prevention career?
Yeah, I know there are still organizations and some hospitals, healthcare systems that are still kind of not, they haven't updated their view of the infection preventionist role. And so there are these limitations as to who can apply to be an IP, who can be hired as an IP. I still see postings, RNs only. I'm like, in 2024, like, you need to
Yeah.
think beyond that. And so I can understand the frustration for nurses that are trying to get in the field. But there are a lot of organizations that are now open to exploring these interdisciplinary teams, and they're the best infection preventionist programs. So look for those. If you're a nurse, don't get frustrated by the few postings that say RNs only. I also would challenge people to look infection prevention now. Like you see a lot of non-traditional healthcare infection preventionist roles. So you see the industry is now looking more into hiring infection preventionists. I know there's the vet hospitals, like these, not clinics but the major vet hospitals, actually now have infection preventionists in residency. And so I think we'll continue to see growth in where IPs can work, and hopefully that diversity would entertain a lot more people that maybe don't want to be in the hospital. I'm also very intrigued and looking forward to the continued conversation that APIC is leading in creating tracks, in academic tracks for infection preventionists. As somebody that went through that program, I think that is something that needs to be on the forefront of every academic program. Infection prevention, the career path, the task force, the workforce is that where it needs to be. We need more IPs than we have. And so academic programs should look to help build that gap by developing programs that will allow students to graduate with the core knowledge that they can now get into the field and learn to apply as well as continue to grow. I think when I think about 5 years from now, I, I would like to challenge healthcare organizations to look at infection prevention as a specialty and create opportunities for growth within the organization so that IPs are not maxing out in one organization and trying to find the opportunities elsewhere. That's the unfortunate part of being an IP. It's like you get to a point where this is kind of the ceiling and that's it. You want more
Hmm.
growth, you have to go elsewhere, and that's very frustrating. But also it can be a disservice to the organization because this is somebody who spent maybe the last 4 or 5 years developing and building programs and working on projects, and now they're having to leave those projects and some of them stall. You'll be fortunate if you have somebody else to pick it up. So it's just makes more sense, in my opinion, to create opportunities so that they can continue to grow and retain them in the organization. So that's kind of my challenge to healthcare organizations, is looking at how you can continue to grow the field of infection prevention, because we all know when you have a strong infection prevention program, your quality metrics are great because of the work that IPs do. And overall safety, a lot of what we do really helps with the safety programs, and so it's not a loss investment. The return on investment is always positive and great.
Yeah.
Thank you for joining us on this episode of Voice for Infection Prevention. We hope you found our discussions informative and insightful. Remember to subscribe to our podcast for more conversations with experts in the field, and don't forget to leave us a review to let us know what you think. For additional resources and to stay updated on the latest news in infection prevention, visit our website at voiceforip.com. Thank you again for listening. Until next time, stay safe and continue your commitment to excellence in infection prevention.